I am I'm Debbie Dyer, cardiothoracic radiologist here at National Jewish in Denver. I also serve as chair of the Lung Cancer Screening Steering Committee for the American College of Radiology and am a current co-chair of the Colorado Cancer Coalition Lung Cancer Task Force. This presentation today is being brought to you by the Colorado Cancer Coalition and the Colorado Cancer Screening Program. So our topic is understanding the new U.S. Preventive Services Task Force recommendations and what this means for patient care and for payers and beyond. And if you are involved in lung cancer screening, which I hope you are, you're probably experiencing just a little bit of this in limbo period that we have right now. So I'm going to try to help get us through that. All right, so my objectives today are to review the newly released recommendations from the U.S. Preventive Services Task Force, talk about the benefits to patients and the timeline for implementation, and then also to discuss the reopening of the Medicare National Coverage Decision for low-dose CT. So this was the great news that we got on March 9th, 2021. We were expecting to receive some updated final recommendations from the task force, because if you recall, last summer they had released some preliminary recommendations. And in fact, our Cancer Coalition did respond to those initial recommendations last summer. So then the task force they reviewed everything, and then they finally came out with this final recommendation in March that lowered the age to start screening to age 50, which had previously been age 55, and they lowered the pack years to age 20, pack years to 20, which had been 30. And if you're interested in seeing sort of a nice review of this whole process, the Journal of the American Medical Association on the same date, March 9th, released this article, and it does describe the process and in a very nice readable format. Just for perspective, if we look back to where the U.S. Preventive Services Task Force was with lung cancer screening over the past couple decades, back in the 1990s, and in specifically 1996, they released their recommendation at that time, and it was given a grade D. That's when we only had chest radiology and sputum cytology. And at that time, screening with those tools, chest x-ray or sputum cytology, was not recommended. And then in 2004, they came out with an updated recommendation of saying that there was insufficient evidence for screening with either CT or chest x-ray or sputum cytology or a combination of these. Now, you might note that in 2004, we did not have the results of our national lung screening trial. Those were not released until 2011. So then in 2013, the U.S. Preventive Services Task Force did release a new recommendation that recommended lung cancer screening with a grade B recommendation. At that time, they recommended screening for patients age 55 to 80 with a 30 pack year history of smoking, for patients who were current smokers or who had quit in the past 15 years. And then now we have our new recommendation. It is still a grade B. I will talk a little bit about that, more about that in a moment. As I mentioned, they did reduce the starting age to 50 and they recommended a decrease in the pack years to 20 pack years. They did keep in place an upper age limit of 80, and they kept in place the 15 years since quit. And this is referred to as the 50-80-20-15 plan. Now, just to also acknowledge that there is quite a review process that the U.S. Preventive Services Task Force goes through, and specifically for lung cancer screening over then the past several months up till March, they did review 223 publications, 7 of which were randomized controlled trials described in 26 articles that involved 86,486 patients. They did acknowledge that the National Lung Screening Trial and the Nelson Trial in the Netherlands were the only adequately powered randomized controlled clinical trials. Also, in the months leading up to their new recommendation, it was acknowledged that there were several new important articles in the literature that needed to be reviewed and addressed that would significantly affect updating the recommendations. And in fact, there was this very important article by Aldrich that was in JAMA Oncology. And this group evaluated the accuracy of, this was the 2013 U.S. Preventive Services criteria in a predominantly African American or low-income cohort. And this involved 48,364 ever smokers, of which 67% were African Americans. The results of this study were that, adjusting for the age and smoking history, that African American ever smokers were at higher risk of lung cancer than white ever smokers. And importantly, there was a smaller percentage of African Americans that met those 2013 task force criteria than whites. And it was acknowledged that lowering the pack year criteria to 20 pack years was associated with increased eligibility for screening among African Americans. So their conclusion was that the 2013 guidelines then were probably too conservative for African Americans, and that we needed to have some race-specific adjustment to the pack year criteria. Another important article that was released in 2020 by Pasquinelli and her team addressed the risk prediction models for lung cancer screening versus the 2013 lung cancer screening eligibility by the or guidelines from the task force. And they were specifically looking at reducing race disparities. And in this study of 64 African American ever smokers that were ineligible by the task force criteria, they found that if they lowered the age, 23.4% would have increased, would have been eligible for screening using the risk prediction model of a threshold of 1.7%. And of 53 African American ever smokers, if the quit smoking age was eliminated, 49.1% would qualify. And of 193 African Americans ever smokers, if the smoking history was reduced below 30 pack years, an additional 40% would qualify. So their conclusion was that the risk prediction model was preferable over the U.S. Preventive Services Task Force criteria in identifying African Americans eligible for smoking, or eligible for screening, excuse me. So when the task force did come out with their recommendations in March 2021, their conclusion was that there was moderate certainty that annual screening for lung cancer with low-dose CT had a moderate net benefit in persons at high risk of lung cancer. And that the moderate net benefit did depend on limiting screening to those high risk, that there needed to be accurate imaging interpretation, and that the resolution of most false positive results should be done with serial imaging rather than invasive procedures. So because of the moderate net benefit, this was determined to be then a grade B recommendation. Just for comparison purposes, a grade A recommendation from the task force requires high certainty that the net benefit is substantial. So the benefits that we anticipate from these revised eligibility criteria from the task force are that the drop in age and the PAC years will help address the disparities in lung cancer screening, and that this 50-80-20-15 strategy will increase the relative risk of persons eligible by 87%, by 80% in men and 96% in women. The new strategy will help address racial disparities, particularly in Blacks and Hispanics, with a relative increase in eligibility of 107% and 112%. So this is significant, and we do have a tremendous opportunity here to bring more people into screening. Now, the task force kept in place other recommendations. They recommended that screening be continued on an annual basis, that age and smoking history to determine eligibility is preferred over the more elaborate risk prediction models because of the complexities of the risk prediction models. Not to say that the models aren't good. They are, but they didn't recommend a model-based approach because they felt it would be an added burden and increase to the complexity of determining who's eligible. They recommended that all current smokers enrolled in screening should receive smoking cessation interventions, that shared decision-making is important, that the decision to undertake screening should involve a thorough discussion about the potential benefits, limitations, and harms of screening. And they acknowledge that Lung-RADS provides helpful guidance on which findings are suspicious for lung cancer, and they may decrease the false positive rates. So just a little side comment here about Lung-RADS. I'm assuming most of you are familiar with Lung-RADS, but just as a reminder, a structured reporting system was required by Medicare, and then the goal of us having a structured reporting system was to decrease false positives and provide consistency in reporting. The Lung-RADS system was adopted by the ACR in May 2014, and it was updated to version 1.1 in 2019. It defines a negative versus positive scan, and it includes an S category for significant incidental findings. This is what it looks like. I'm guessing that if you're working in a lung cancer screening program, your radiologists have this printed out and laminated and at their workstation, or else they have it on a side PC, because this is impossible to remember off the top of your head. But to note here, this Lung-RADS is a system of 0 to 4 that basically looks at the findings and categorizes them as negative, benign, probably benign, or suspicious, and then that is based on the findings as what the findings are likely to be then as far as their risk of malignancy. And then there are established guidelines or recommendations for management based on the lung RADS numbers. So just to zero in here on the negative screens, which are those that are the lung RADS 1 or 2, and the negative one either has no nodules or clearly benign appearing nodules. The benign appearance or behavior, the nodules here have to be less than 6 millimeters in diameter if they're solid, and less than 30 millimeters in diameter if they're ground glass. The recommendation is follow-up CT in 12 months with an assumption that there's less than a 1% risk of malignancy. The probably benign category is the lung RADS 3, and these are nodules between 6 to 8 millimeters if they're solid, or greater than 30 millimeters if they're ground glass. The assumption here is that there's a 1 to 2% risk of malignancy, and a 6-month follow-up low-dose CT is recommended. Now, where we get into really identifying those suspicious nodules is in the lung RADS categories of 4A, 4B, or 4X. And as you'll notice, then the risk of malignancy has increased here. And for the 4A, it's between 5 to 15% or greater than 15% for the 4B or 4X. And the recommendations for management then are more aggressive. So for the 4A, it's typically a 3-month follow-up low-dose CT, or a PET CT could be performed if it's more suspicious. And then for the 4B category, we definitely then are recommending more immediate action of a PET CT or tissue sampling. And if a nodule has appeared sort of suddenly, looks infectious, a 1-month low-dose CT could be performed. And the assumption there is it's probably infectious or inflammatory and is going to go away. And this is just showing you how this system works. So here was a lung RADS 4A nodule in a patient. It was part solid. And so the recommendation was a 3-month follow-up. The patient came back in 3 months, and you can see how the solid part has increased overall. This is now a lung RADS 4B. The recommendation here was then for tissue sampling. The patient was biopsied, and this turned out to be an adenocarcinoma. It was resected through a minimally invasive wedge resection, and this was a stage 1 and considered a cure. So this is exactly what we're trying to do. So now back to our new recommendations from the task force. And what about the timeline? Well, within the Affordable Care Act, commercial insurance and state Medicaid programs that were in expansion states, which is Colorado, then within the ACA, these providers are required to cover low-dose CT as a preventive service with no copay or cost sharing to the patient. And that's because we got a grade B, or if we've gotten a grade A. Now, the tricky thing is the commercial insurance providers have up to 1 year from the date of the start of their next year plan to implement the new criteria. Payers may voluntarily cover the new population of folks sooner. And the good news is that Aetna has already done this. At the national level, Aetna has released their policy that these new guidelines should be adopted. Now, it may take until March 2023 if, let's say, a commercial provider had just renegotiated a contract on March 8th of 2021, they would have until March of 2023 to adopt the new guidelines. So until the new coverage is in place, patients and referring providers and screening programs will need to advocate for coverage with the insurance providers. Now, as far as Colorado Medicaid, they have not indicated any change yet or what their timeline is going to be. Some of us have requested a meeting with the folks at Medicaid, and we're currently trying to get that set up. They were receptive to having a meeting about these new recommendations. So hopefully when we get that set up, we'll be able to get an indication from them of their plan for what to adopt the new guidelines. Medicare is a whole different ballgame. They are not required to adopt the U.S. Preventive Services Task Force recommendations, but after the recommendations were released from the task force, Medicare did agree to reopen their national coverage determinant. And so we are currently in a process now where they are evaluating what their coverage will be. Now, as far as the private payers, the commercial insurance providers, the American College of Radiology, along with the Society of Thoracic Surgeons and the Go-To Foundation for Lung Cancer, we did submit a formal letter to the top 5 national insurance providers and asked them to not delay their adoption of these new coverage determinants and asked them to adopt them as soon as possible. As I mentioned, Aetna has responded and they said they have changed their recommendations. So far, we have not heard anything official from Anthem or Cigna or United Healthcare or others. So what can we do now? If you are with a lung cancer screening program and you are wanting to get your patients covered, the ones that qualify under these new recommendations, I would suggest that you go ahead and submit a request for pre-auth to the commercial provider. For these folks, you will have an opportunity in that process to educate these radiology benefit managers that work with the insurance companies and to offer them information. And you can send them a letter with information about the new guidelines. I'm going to provide you with a copy of that letter template in a moment. We can also ask our patients to advocate for themselves and to contact their own insurance providers and say, hey, I know that I'm eligible now. Why aren't you covering? And then if all else fails, and if the insurance company denies, then you can certainly offer lung cancer screening to these newly eligible patients with a self-pay option. Now, here is a sample letter template. This is basically taken from the letter that the ACR and the Society of Thoracic Surgeons and Go-To Foundation sent. And we just took out all of the references to those organizations, and we're saying to you that you could create your own letter based on this template and then just insert your name and the insurance company and so forth. This is not the entire letter. This is just the top portion of the letter. I will make sure that we have this letter available to you. We can ask Christy what the best way to provide it to you might be. I'm happy to send you the letter template myself. And if Christy wants to be able to post it maybe on the Cancer Coalition website, we could also do that. Now, the other sort of interesting thing going on now in parallel is that the Centers for Medicare and Medicaid have reopened the national coverage decision for low-dose CT. And we just completed the initial 30-day comment period that ended this past Wednesday. Literally everything in that coverage determinant is on the table. Medicare could take away or change or revise anything in it. Certainly what we hope is that CMS will reduce the complex eligibility requirements for reimbursement, which have been viewed as barriers to more widespread adoption of lung cancer screening. And then CMS will be doing now its own evaluation of the evidence. They're going to assess the utilization of lung cancer screening, and then they will review those submitted comments. We optimistically hope to see a new NCD in place by January 2022. I have no guarantee of that. Just talking to folks at the national level, this is what our hope is. Now, I will tell you that our lung cancer task force in Colorado, which is part of the Colorado Cancer Coalition, we did recently prepare and submit a letter to CMS to ask for specific things. And the first thing we asked for was that CMS decrease the starting age to 50 and decrease the minimum PAC years to 20. This would then align with the new U.S. Preventive Services Task Force recommendations. If CMS doesn't do that, then it's really going to add complexity to all of our lives. Now, we also asked that CMS eliminate the 15 years since quit requirement. Now, we do know that the risk of lung cancer gradually decreases in folks after they have quit smoking, but we also know that the risk of lung cancer increases with advanced age, and as you get older, your risk increases, and that there's no dramatic change in your risk at year 16 since quit. And in fact, there's very little evidence that there's any significant decrease in risk after quitting. So we did include in our letter, as did other organizations that I know that I participated in sending letters, we all have been asking for that. We also asked for that, though, last summer when we submitted comments to the U.S. Preventive Services Task Force, and they did not agree to this. So we would like to think maybe CMS would be more flexible and look at eliminating this quit year requirement. We also asked that CMS eliminate the upper age limit of 77. Kind of oddly, you know that the 2013 Preventive Services Task Force recommendations had an upper age limit of 80, which they kept. But when CMS provided their initial NCD on lung cancer screening, they chose an upper age limit of 77. So that's always been a little bit of a complication for those managing lung cancer screening programs, because theoretically you could go up to 80 if you had private insurance instead of Medicare. But either way, we are recommending that the whole upper age limit be eliminated. And in fact, that patients be evaluated on an individual level for their comorbidities, their life expectancy. And one 80-year-old can be very different from another 80-year-old, or one 77-year-old can be very different from another. So the recommendation is to just eliminate the upper age limit and have it be an individual decision of the patient with their provider, if in fact they are appropriate for screening. We also recommended that a risk prediction model such as the PLCO model that some of you may be familiar with or referred to as the Brock model, that these models be added as an option for eligibility. So certainly we know the task force recommended that age and smoking history be used, and they advised against the prediction model because they thought it would be too complicated. But if you have a program that is set up and able to do these risk prediction models, it would be ideal if patients could qualify either through the age and smoking history criteria or also have these models as an option. And we know that other patients will be eligible using these models. We also asked them to reevaluate and revise the requirement for shared decision making. And it was interesting, within our own lung cancer task force, there was considerable discussion about there is truly a value to shared decision making, and we want to acknowledge that. And some folks on our task force felt like the requirement for shared decision making should just go away completely. Others felt it was extremely important that the shared decision making be done because we know it contributes, in fact, to patients' adherence to annual lung cancer screening. So our task force ended up asking that Medicare acknowledge that having shared decision making as a requirement for reimbursement is a barrier, but in fact, one of the things that might help is to expand the pool of people beyond licensed providers, which right now you have to either be a physician or an advanced practice provider to be able to provide shared decision making to patients and be reimbursed for it. But we, as a task force, were recommending to CMS include other people. Make it so that the navigators or the lung cancer screening program coordinators or respiratory therapists or nurses that may be involved as then nurse navigators or coordinators for screening programs, those other folks also be able to provide shared decision making. And in fact, we know that since those folks are often much more involved and aware of the eligibility requirements and they get questions from patients, that they're probably more knowledgeable about the risks and benefits of lung cancer screening. So we'll see where that goes. That's going to be a very interesting pursuit for Medicare for whatever they decide to do with shared decision making. One of the things that has certainly been acknowledged and is a concern is that shared decision making isn't required for colon cancer screening, and it's not required for breast cancer screening or mammography. So the fact that it was required for lung cancer screening was a concern to many folks, and many folks think that that is one of the barriers to getting people in. So it is a challenging discussion, and there's maybe not one absolute right answer. Further, we also asked that low-dose CT, could be performed at independent diagnostic testing facilities. I'm not sure if you're aware, but right now Medicare requires that low-dose CT be performed at imaging centers that are not these qualify as an IDTF. And the crazy thing, the reason for this is that the facilities requirement in the national coverage decision said that the imaging facility had to provide smoking cessation information to patients. Well, nobody has a problem with that, but they interpreted that delivery of smoking cessation information as a therapeutic intervention. And IDTFs are not able to deliver therapeutic interventions. So in fact, this has limited the access to lung cancer screening. So smaller imaging centers have not been able to do it. Now, at the same time, we do want to acknowledge that we want to provide increased access and have these CTs be able to perform at these imaging centers, but we also want to see the imaging centers linked with referral centers if in fact there's a positive scan and a workup is needed. Now, we also ask that the pre-auth requirement for Medicaid, and Colorado is only one of 13 states that requires a pre-auth for lung cancer screening. So we asked that the pre-auth requirement be eliminated, and that if the national CMS can have any influence on these state Medicaid programs, we ask that they acknowledge that. And then the other item that we asked for was to encourage modifications to electronic health records to standardize smoking history and the gathering of risk factors. Actually, what CMS could do is provide perhaps some financial incentives to these EHRs to do this, to promote lung cancer screening. Now, one other thing that I wanted to make you all aware of, you may already know, that another bit of good news that we all received in March was that the American Academy of Family Practice, obviously a large group of primary care providers, they changed their recommendation on lung cancer screening in March as well. And previously they had said there was insufficient evidence to promote or encourage lung cancer screening. And in March, they gave lung cancer screening also a grade B recommendation. So we should have a lot more primary care providers then on board and able to recommend lung cancer screening to their patients. And then just to give you some overall numbers about lung cancer screening at a national level, as you know, it is a requirement by Medicare that lung cancer screening patients be reported to the National Registry. You can see a significant growth in the number of patients that were submitted each year from 2016. Unfortunately, in 2020, we did see a drop, probably in large part due to COVID. The drop was small, but what was really significant here is that we were on a trend of really increasing the number of patients screened. And so now we have to make up for that lost time. But there's no doubt here that we are not screening all the patients that need to be screened. And so we need to do whatever we can to make screening easier. And so the challenge is that only about 4 to maybe up to 12% of eligible patients are currently getting screened, likely due to the significant barriers. Currently, there's about 9 million Americans that are eligible. With the new U.S. Preventive Services Task Force recommendations of age 50 and 20 pack years, we expect there to be a considerable increase, almost 50%, in the number of eligible patients. One of the things we also know is that patient adherence to annual screening is only about 50%, and certainly we saw a drop in adherence over the past year related to COVID. But we have an opportunity. With the new U.S. Preventative Services Task Force recommendations, I think we can regain some momentum, get more patients back into screening, but we also have to acknowledge that we're going to be in this weird transition period, which is going to make confirming eligibility for patients eligible even more challenging. And then for further info, and then right now I'm certainly willing to take any questions you might have, but for further information, if you want to contact me, feel free to email me. I'm at dyerd@njhealth.org. So I'm going to stop sharing my screen, and if we have any questions, I'm delighted to take questions. And I know there's some things in the chat. So there's a very good question here about, is there a letter template for patients? You know, we haven't developed that exact tool. There is a committee at the American College of Radiology that is actually working on that and working on other materials that are directed to patients. But I noticed it was Lisa, who is a patient advocate, a lung cancer survivor herself, on our lung cancer task force. And Lisa, I'm happy to send you that letter. And, you know, if you wanted to make any edits to it that you thought might be helpful for patients, I'd love for you to do that. And we could internally, here at our own state level, create a template for patients. So I'm really happy to do that. So that was a great question. Any other questions out there? It is such a difficult time, but it's such an opportune time and a good time for lung cancer screening, if we can kind of all wrap our heads around that, because I think we really do have a chance to gain some momentum with these revised eligibility criteria. Well, Christy, is there anything else that you would like to share with the audience?
It looks like Andy just put something in. Could you remind folks what the current rates are for those who we think are eligible for lung screening?
You mean the rates of people enrolled? So only in Colorado, we think only about 4% of eligible patients are getting screened. And that is with the age 55, the 30 pack years of, they have to be current smokers or quit within the past 15 years. And the upper age limit is 77 for Medicare and 80 for Medicaid and commercial providers. Obviously, patients also, we have to have documentation that they have no symptoms of lung cancer. The symptoms that we traditionally use as specific for lung cancer, if you will, is if patients are coughing up blood or if they have unexplained weight loss. A cough or shortness of breath is quite common in the lung cancer screening population because many of them have COPD, but those are not considered symptoms of lung cancer. And then, of course, the requirements for Medicare are over and above just the eligibility requirements. The requirements from Medicare are that patients have to have a visit with a licensed provider for shared decision making. That has to be documented. And then there has to be an order for lung cancer screening, that the patient's data from the lung cancer screening exam has to be entered into the National Lung Cancer Screening Registry. Currently, there is just one registry, which is authorized by CMS, and that is at the American College of Radiology. So we do have a number of restrictions on eligibility that we have to make sure we comply with. And then there are facility restrictions that Medicare also has, that the places eligible to do lung cancer screening. Let's see, any other questions? Oh, how do we compare to other states? um, so unfortunately, those of us in the Western United States have some of the lower levels of uptake. We're all around the 4% level. In the Eastern United States, Massachusetts has the highest level of uptake. I think they're around 14 to 16%. And then even in states like Kentucky, where they have a high smoking rate, but they also have very organized lung cancer screening programs, they are up around the 10 to 12% rates too. Some of the other states in the South, though, have lower uptake, which is unfortunate because there are higher smoking rates there. But Colorado, we're not up there in the high category. But, you know, I think we certainly have our lung cancer screening collaborative that we formed over the past year, and we had our initial symposium, if you recall, last fall. So I think we're making great strides here, and we have a wonderful team of people. We are so lucky to have the folks at the health department that work closely with us. We have Christy with the Colorado Cancer Coalition. Christy is just tremendous at keeping us all organized. We do have our lung cancer task force, and any of you who might be interested in joining our task force, please let Christy know, and she'll get you linked up with our task force. And then we also are fortunate at the University of Colorado, there are a number of research programs looking at lung cancer screening, at adherence and uptake in rural areas. So I think, you know, we're on the way. We are considered actually nationally a leader in lung cancer screening, just because we do have so many great folks in this state working on efforts. Okay, here's a question about blood testing. So there is some blood testing that some people call it liquid biopsies. There is a move towards, are there markers, certain markers that people may have in their blood that would indicate that they're higher risk of lung cancer. Currently, these are all still in the research stage, but one of the models, goals perhaps in lung cancer screening, and particularly to address those that are non-smokers, would be to have biomarkers, these blood tests that would indicate patients who are high risk who could then get CT screening. And we National Jewish, we are involved in a couple studies looking at these biomarkers. There is a definite opportunity, and it's not out there yet just for public consumption, but I do think that is one direction that we're headed. And I think that's going to open up then the opportunity for others to get screened. So I would say stay tuned on that. There are a number of companies working on this. Any other questions?
I did put a few links in the chat for the cancer partner meeting coming up on July 22nd. And then I put the link in for the lung cancer task force as well. So if you want to learn more about the lung cancer task force. And then there's also an evaluation. So please be sure to take the evaluation.
All righty. Well, I thank you so much. And I thank you for all the work that you're doing out there as advocates for lung cancer screening, promoting lung cancer screening. And certainly if you're involved in lung cancer screening programs, thank you for getting patients in and getting them screened. Thanks so much.
Thank you, Debbie.
Bye-bye.
All righty. Bye, everyone.